Welcome to Derms on Drugs, a new video podcast brought to you by scholars in medicine. Derms on Drugs is where cutting-edge derm meets mediocre comedy. I'm Matt Zyrus, nowadays a private practice dermatologist in Columbus, Ohio. And each week I'm joined by my residency buddies, Laura Ferris, who is now the chairwoman of dermatology at the University of North Carolina, and Tim Patton, who is faculty at the University of Pittsburgh, to use our 60 years of combined experience to discuss, debate, and dissect the hottest topics in dermatology. It's everything you need to know to be on the cutting edge of dermatology, and it'll be the most fun you've ever had while actually learning something useful about dermatology. So tune in every Friday, only at Scholars in Medicine. And with that said, we're going to jump into the first segment of our show. So as you may know, we break our show down into the big three, where we talk about our three favorite articles of the week. Then we go into our deep dive, and I could not be more excited to have somebody on who is going to hopefully make you have thoughts that you have never had before about the topic of ultraviolet light and its health impact. And then we're going to talk about a few more articles after that. So let's go ahead and get into it. Laura, I believe you've got our first article today. Yes. Go ahead and jump in.
All right, so I am going to be talking about a publication that was in JAD, Sustained Hair Regrowth with Continued Ritlecitinib through week 48 for patients with alopecia areata. So this is a post-hoc analysis of the Allegro phase 2b/3 trial. So what did this show? So, the first thing it showed was sort of what you might expect, which is that most people who are responders at week 24 still respond at week 48. So, important to show, but I thought not the most interesting part of this study. I thought that the most interesting part was looking at what happens to people who are not responders at week 24, and if you continue them on drug, what happens at week 48? So if we define non-responder as patients who do not achieve a SALT score of 20 or less, so SALT score meaning the extent of your hair loss. So if they didn't reach only 20% hair loss, those were considered non-responders. So first of all, who were these people? So you're less likely to be a responder if you're male, if you've got more extensive AA at the start, meaning either you had a higher SALT score, like maybe a SALT 100, you had complete hair loss, or if you had alopecia totalis or universalis, longer duration of disease, and also if you had more eyebrow and eyelash loss. And so, what we can see is that basically a quarter to a third of non-responders at week 24 actually did respond if you went out to week 48. And we also saw, better eyebrow and eyelash regrowth too from week 24 out to week 48. So, can you determine who these people are going to be? Should you just say anybody should just go to week 48? It turns out that if you really saw like almost no hair regrowth at week 24, you weren't going to miraculously see a great response at week 48. So, in general, you're looking for those people who may have, 40, 50% of regrowth, but they haven't reached that SALT 20. And so those are the people. So I thought this was helpful guidance. I think it's also helpful in terms of counseling patients. What do you guys think?
So I thought that it was super useful to know that if you've had nothing at 6 months, it's basically probably time to switch up and try a different agent or do something else. And the other thing that's just fascinating me about alopecia areata is what a strong correlation there is between severity of disease and duration of disease and response to therapy, and how that's kind of different from other diseases in derm. That I don't think of it as being, oh, you've got 50% BSA of psoriasis, so you're less likely to do well, or you've had psoriasis since you were 30 and you didn't get it till you were 70. Like it's been interesting, but that 6 month cutoff I found super useful.
Patton?
Yeah, except those curves were still going down, right? I mean, we don't have any other options, right?
Well, we got parasitic.
Well, so fine, but I think they're comparable. JAK inhibitor, very close to the JAK MEK or whatever they're classifying ritlecitinib as. I think if the patient was tolerating it and they probably maybe have a little bit of peach fuzz, I think I would probably keep them on it, right? I mean, we've seen this with the JAK inhibitors and alopecia areata.
All right,
It
Patton,
takes forever.
I'm going to give you the two secret Xyrus hacks for alopecia areata, and these are
Okay.
relatively literature based. There was one study of 8 people with alopecia universalis and totalis, who they started all 8 on prednisone along with berry, tapered the
Yeah.
prednisone over 3 months, and all 8 regrew and then maintained. And then there's
Yeah.
also some good data looking at AT and AU, using them using clobetasol under a swim cap until you start to get regrowth. So now because I didn't want to do either of those at the start, but now my spiel is, if at 6 months you're not getting better, I'll add 3 months of prednisone, or I'll try the clobetasol under occlusion.
Yeah, sure, that makes sense. And I wonder, topical immunotherapy, adding that to JAKs, that seems like, because they're anti-inflammatory, maybe it would make that less effective. I don't. I
Seems like
wonder.
right. All right, let's go on to our. Let's go on to. Ferris, anything you want to finish on that one?
Nope.
All right.
Go on to the next one.
Patton, let's go on to our next one.
All right, big 3 paper in the January JAMA Derm by Seneschal et al. Titled Combination of Baricitinib and Phototherapy in Adults with Active Vitiligo, a Randomized Clinical Trial. Study was conducted in 4 hospitals in France, consisted of 49 patients with active non-segmental vitiligo. That did seem to be important. The patients either had to have new or expanding patches of vitiligo within 6 months.
Okay.
They also had to leave 5% body surface area and the presence of hypochromic aspect or perifollicular. Like, they really kind of selected these for
terrible.
These are active vitiligo. 12 patients took placebo for 12 weeks. 37 patients took berry 4 milligrams for 12 weeks, and then both groups got into the narrowband UVB.
Did they have narrowband the first 12 weeks also?
No.
So first 12 weeks were just placebo or drug. Correct. Then at 12 weeks, everybody started narrowband.
Right, and they continued to take either placebo or the baricitinib.
All right.
So Figure 2 shows improvement in the mean VASI in both groups. It's better in the berry, so a mean of 44.8% improvement in the VASI, mean VASI, compared to 9.2 in the placebo. This was measured at week 36. So and the supplementary material, there were some clinical photos showing improvements, and these were obviously cherry picked by Eli Lilly. But basically the person who got the placebo plus light, this was a face VASI, got worse. The other 2 had pretty decent responses. I thought it was interesting that the bottom picture, you could see the effect that goggles have on eyelid repigmentation.
It never occurred to me it was the goggles.
I'm assuming that they didn't specific. I was looking for the protocol.
Has to be.
Yeah. Figure 3, top 3 graphs, different measures they had. VASI 50, VASI 75, face VASI 90, all of which better in the berry group. And then figure 3D shows DLQI, which is about the same at 12 weeks. So that's kind of funny. Berry and placebo, they both had slight improvements. And then you started to see a little bit of separation. It looks like 24-36, it was a good separation, but the text says that it was only statistically significant at week 24. Interestingly, the other quality of life measures didn't show any difference between the groups. And then I think one of the big things they kind of brush by in the text, because they're like, adverse events was about the same, but one of the subjects in the berry group had a pulmonary embolus.
Okay. So
do you see systemic JAKs taking on vitiligo here in the U.S. someday?
So I just started doing the ritlecitinib trial for this, and I'll say it is slow, so I'm not surprised nothing happened in the first 12 weeks in the berry, right, that their quality of life didn't get any better. I was mostly shocked by how lousy narrowband UVB worked on its own, that 24 weeks twice weekly.
Too.
So, but what you said of them selecting people with perifollicular, people with some leukotrichia, that makes more sense.
So that was their theory, was berry's going to stop the active disease from progressing. Then you hit them with the narrowband. That's going to allow the repigmentation and things like that we usually see. So
yeah, and it makes sense to put together something to stop the immune attack and then something else to stimulate the melanocytes. Ferris, what are your thoughts? Anything?
Yeah, I thought it was interesting. I have not done, obviously, well, maybe not obviously, systemic JAK inhibitors for vitiligo. I've done topical. I have found that they work better if I do it together with either eczema or narrowband. So it kind of supports that. I think to me the question will be, when do we go to a systemic JAK versus a topical?
Yeah.
But putting it together with
Just
UVB makes sense
And
to
just
me.
out of an interesting thought, it makes a lot of I'm doing now for my primary treatment for facial vitiligo, Opzelura, and then I'm using topical bimatoprost together with it because you can get the little generic bottles of bimatoprost eye drops like really cheap. And so for 3 months, try and stimulate your melanocytes with that in addition. All right, so let's move on to our final big three article, and this one, our first two, we're really looking at therapeutic interventions and how to use them most effectively. This one is totally different, and I'm so excited to go into this with our deep dive guest, who is one of the authors and who's driving all this work. So, higher ultraviolet light exposure is associated with lower mortality. An analysis of data from the UK Biobank cohort study, and so essentially, the biobank is, to my understanding, about 500,000 people that they've, drawn blood, have genetic sequencing if they need it, all of these health questionnaires. They know their social determinants of health. Like they are a very well categorized group, and it makes it incredibly powerful because then you can really match people very well based on, other potential confounders and hopefully rule them out. So that is what they did in this study. So they compared people, either people who said they used a sunbed, went tanning, and then followed them over. I think it was about 6 years on average. And they also looked at the average UV radiation where you live based on sunlight. So using satellite data and that kind of stuff. And they showed a pretty dramatic reduction in all-cause mortality with either tanning bed use or living in areas that have more sun. And it was kind of a linear relationship. This tanning bed use, we didn't have data on how much they used the tanning beds, but with the sun UV, we did. And there was a relatively linear relationship. The biggest effect is on cardiovascular disease. There's also a significant effect on cancer disease, on cancer deaths, and even on non-cancer, non-CVD deaths. So on every marker, it improved overall survival. Now, when we talk about skin cancer specific survival, the people who used the solarium or got more sun did get more melanoma, but they were no more likely to die from melanoma. And so the question becomes, do these advantages, so first, if these advantages in when I say if, like, to me, it is very well proven now, but if these are real, which I believe they are, if they outweigh the number of deaths from melanoma, it may turn out that it's there's this risk benefit where it's actually, we should be telling people get more UV, might increase your risk of skin cancer, but it's going to reduce your risk of dying from all this other stuff even more than it increases your skin cancer risk. And you can't get it from vitamin D. So vitamin D doesn't help with any of this stuff. And that's one of the crucial parts. So before we have our guest on and kind of start going into this whole topic bigger, because there's a long body of literature on this, that this is sort of the capstone of. Pat and Ferris, any initial thoughts on this?
I thought vitamin D is really more of like a biomarker of UV exposure than what is actually mediating the response. The solarium use is tough because somebody has used a sunbed once versus, has one in their basement like we see in the US. Those are two very different, exposures. I think it's interesting. I think it's also really hard. There's collinearity probably with using a tanning bed or being outside a lot or tanning and exercise and some other things
I
that
think
might
I think they
potentially.
controlled pretty well for
Yeah,
all of that stuff. I think they,
I think it's hard to fully do it. It's hard to fully
yeah.
control for those things, but I agree. I mean, I think it's very interesting, Patton.
I think it's interesting, and you know, I started to think, all right, I totally, completely buy into this. I, what? How would I change my life? I wouldn't change anything. I mean, I'm not horrified of the sun,
But what about your
but
patients? What are you going to tell your patients?
I think that you risk stratify, and I think that you know this was kind of brought up in Australia. I think in January last year, January February last year, they basically risk stratify their patients and they counsel them based on you know what type Fitzpatrick you are. It's a more reasonable counseling that I think makes more sense as opposed to just maybe saying what we tell our patients. You need to protect your sun or protect yourself from the sun and UV. That's the most important thing. But I also do think that America is not England. There was another study out of Sweden. Like we just aren't the same as in terms of our sun exposure. So
Right.
does that make a
Is
difference?
it relevant to people who live in North Dakota only, or is it also relevant to people who live in Ohio and Pennsylvania and North Carolina? Right.
Yeah.
That's the other question. Well, let's from there because we got some interesting questions, and I think we've got probably the best person in the world to answer them. So I want to introduce Dr. Weller. So he's Professor Richard Weller, dermatologist at the University of Edinburgh, who has been doing this work for decades, and I think every possible argument against it he has heard repeatedly, and I really can't wait to get into this. So, Dr. Weller, the first thing that I really want you to start with is because we got to get people to buy this as possible. And so to start, explain the mechanism by which UV reduces cardiovascular morbidity and mortality, and if vitamin D supplements help. And we're going to really stick to cardiovascular because I think that's got the best data. But let's start with that question. Does vitamin just take your vitamin D pill and stay out of the sun?
Yeah, Matt, great, thanks. And look, it's great to be here. I spent 2 years in Pittsburgh doing research, which is actually where a lot of this started off. So it's great to be back with some Pittsburghers discussing this. So yeah, so mechanism. So look, I think so. I suppose the first thing to say is vitamin D is being hugely overplayed. It's got some benefits. Yeah, it prevents rickets, and there's all these
I see a lot of that.
observational.
See a lot of
So you know, yeah. So there's all these observational studies. People with higher measured vitamin D levels are healthier in pretty much every way you can imagine. And but correlation is not causation because we've now got the results of all the clinical trials. The biggest single one, of course, run in America, the Vital study, the biggest of all, run by NIH. And actually, when you give people vitamin D, it doesn't do much. As you said, Laura, it's a biomarker for sunlight exposure, which prevents rickets in children and probably doesn't do very much if you're going to believe randomized, double blind, placebo controlled clinical trials, which I think are a powerful tool that we should listen to. So, if it's not the vitamin D, what could it be? And the mechanism I've really discovered is this nitric oxide release. So, you know, it turns out that the skin contains large stores of nitric oxide. I was studying this down a blind alley in Pittsburgh. If you watch TED Talks, I gave a TED Talk on this. And we found the skin contains large stores of nitric oxide, which are released, which are photo released by UV when it hits the skin.
A or
And
B?
that then
Or what is it?
well, so interesting. In my original studies, we used UVA. That was really to show this was a vitamin D independent effect because vitamin D is made by UVB, and I wanted to show that there's a vitamin. This is a vitamin D independent thing. So I used UVA lamps in my human studies, but I suspect UVB is actually as important, if not more so. But we discovered it releases NO into the circulation, vasodilates, lowers blood pressure, and high blood pressure is the biggest killer in the world today. You know, it accounts for it's 18% of all deaths in America are directly related to high blood pressure. And we also showed then in later studies we did in America that actually skin color really matters. So we looked at dialysis patients mostly because they get their blood pressure measured 3 times a week, week in, week out, year in, year out. And we took a data set by the Fresenius, who run most dialysis units in America. And they've got 350,000 patients on dialysis in 2,000 different centers in America. And we could look at their blood pressure 3 times a week over 3 years in 2,000 different centers. We could then look at effects of wavelength, UVA and B. We could look at skin color, really importantly. We could look at temperature. And what we showed was that more UV, lower blood pressure, important, but that fall in blood pressure was much less marked in Black Americans than white Americans. And of course, skin color determines our response to UV. That's what it's about.
And did you guys
So
were you able to rule
yeah,
out in that temperature wasn't the issue? Because you hear that all the
and
time.
indeed,
That
yeah.
more blood
So
to your skin
yeah,
your skin when it's warm, so you get. But that didn't show the same.
we did indeed. So look, so about half the seasonal variation is due to temperature, but about half of it is independent of temperature.
Okay.
And that's really important. So it's not vitamin D, the clinical trials show that. About half of it, about half of seasonal variation is temperature, but half of it is UV independently of temperature.
Okay. Laura, what's the first question you've got for Dr. Weller, Laura?
I can understand. I mean, I think that the data are interesting. There's a plausible mechanism for this. I guess my question is like, how much does it take, right? So patients always say like, oh, they're always worried about making vitamin D, which I think we can say that's actually not what you need to worry about. But it's like, what's the dose response here, and how can you get to it?
Yeah, look, so the answer is we don't know because we haven't done the experiments. What I would say is that in Northern Europe, the seasonal variation in blood pressure, so the difference between winter systolic blood pressure and summer systolic blood pressure, is about 6 millimeters of mercury. Now, so if you were experiencing summer levels of sunshine instead of winter levels of sunshine, that would lower your blood pressure by 6 millimeters of mercury. Well, what does that mean? Well, that means a reduction in your risks of death from cardiovascular disease of 23%. That is huge because cardiovascular disease is the biggest killer in North America, Europe, and the world now. And this is huge. Now, and so we have this, look, it's currently midwinter here in Britain. We are having our usual winter bed crisis. When I was a young doctor, every winter you have a bed crisis. I have to say the modern NHS, we have a bed crisis 12 months a year, but it used to be a seasonal thing. And it progress. We love it. And we know that people are sicker in winter. Hippocrates described this 2,500 years ago. There's a kind of culture as an internal medicine doctor in Britain that you don't take your holidays in winter because it's bad form, because everyone's bloody busy. And if you're on vacation, you're dumping your colleagues in it. It's an unstated rule. It's just how the world is. And so nobody thinks about it. Why is everyone sicker in winter? Hippocrates observed it, didn't explain it. And it looks like for cardiovascular disease, a big part of it is sunshine.
All right, I got to ask this because I follow this literature pretty carefully, Laura. So there was that Korean study that people getting narrowband UVB for vitiligo got a 30% reduction roughly in cardiovascular morbidity and mortality. And that made me think, well, looks like getting 2 minutes of narrowband UVB 2 or 3 times a week is probably enough. If you were to use this interventionally, if somebody was to be like, hey, Dr. Weller, we think there's a quadrillion-dollar business in America. People will love to be tan. We can't get them out of those damn tanning beds anyways. Let's make narrowband UVB tanning beds. How often do you think people should go in to get most of the benefit?
Yeah, really interesting. And I know that study very well. I reviewed that for the JID. So it was sent to the, am I allowed to say this?
Yeah.
I reviewed it years back when it came out, and it was submitted to the JID. And I have to say, it was really poorly analyzed when they first did it. They'd looked at people who had, so they compared people that got their vitiligo treated with narrowband UVB phototherapy versus people who had it treated with topical steroids, and they took it from the health data in Korea. And the great thing about vitiligo, if you're looking at psoriasis, they've got so many bloody comorbidities. I mean, psoriatics are unhealthy people, so you can't do it there because the comorbidities kill it. But vitiligo, you don't really have comorbidities. It's a very clean population group. You're just treating them with UVB. And their initial analysis, they looked at people that got a bit of UVB, then a bit more, and looked at lifespan. But the problem there is what's called a mortal time bias. You have to live a long time to get lots of UVB. So, you reverse the argument. And the other reviewer and I went, no, you can't analyze it like this. Go and do a case control. Look at people that have lots versus steroids and just do that. And a couple of iterations, and we were all lined up. The paper got better and better every time. I have been earmarked to write an editorial on it in the JID. We were all lined up. The paper was great. And the authors thought, oh no, they're sending it back. They don't want it. And they sent it to a lower ranked journal. I won't look up the journal yourself. And what I would say to anybody out there writing papers is the reviewers are often on your side if they're saying something.
When I don't like an article,
your enemies, they want to make it better. And that paper's a damn good paper.
Yeah,
and I did
yes.
Of it,
all right, so
as did the other reviewer.
And
so look, so
wait, let me finish this. So twice a week, you think that's enough?
So I don't. The answer is I don't know. What I would say is don't get, but it's interesting. So look, we use UVB to treat inflammatory skin disease. Psoriasis, bit of eczema. It's a great treatment for inflammatory skin disease. My strong suspicion, also based on work I'm doing at the moment, is that actually it may well be a systemic anti-inflammatory treatment, and actually probably far more important than just an inflammatory skin disease treatment. So yeah, I think we're talking about that vitiligo study, and wasn't it fascinating when you combine the Barry with the phototherapy, then you get the benefit. And I mean, I think lots of.
All right.
One question just about like the level of exposure. So I like the vitamin D as a biomarker of UV exposure. Interestingly, I think it was NHIS, but it was like from one of the health interview studies, where they also had labs. They looked in, people's reported sunscreen use and shade-seeking behavior did not correlate with their vitamin D levels. So I guess one question is, can you still get, beneficial exposure while still using some kind of shade seeking, like and some kind of sunscreen level that would prevent or reduce your risk of skin cancer specifically?
Yeah, look, don't get sunburn is the important message. I have to say we've done some unpublished work where we show that factor 50 SPF 50 sunscreen blocks NO release, and that is more of a concern to me. I mean, that's a concern to me. The truth is, we know that patients don't put enough sunscreen on, so, the SPF 50 is a theoretical lab test. There's no relation to the SPF when it's applied. So I think sunscreen can be better than it is, I suppose.
All right, Patton, so Tim is often our biggest skeptic of anything. But maybe we got you already, Patton. What do you got?
No, I am maybe skeptical on both sides. I think that, the shield yourself from the sun, things like that, I think that's a bit much. I did, in reading some your papers and some of the references that you had mentioned, I wound up chasing down this one paper, American Journal of Epidemiology, 2013, and it was prospective study of UV radiation exposure and mortality risk in the United States, where they actually, they set their definition of how they were defining who got more UV versus less, but the patients who seemed to get more UV by the way that they determined it actually had worse cardiovascular mortality. What was your comment on that? Did they not really look at like UV exposure?
Yeah, look, so that's the only paper I've looked really hard for papers on sun exposure. That is the only one I could find.
Pat. You found the one article in the world ever.
And basically, what they found was that people in Louisiana die more than people in New Jersey. because they compared, I think, 6 states.
Yeah.
But what was interesting was the mortality was not cancer. The big cause of mortality was respiratory disease. Now, if we're saying that cancer's UV's great danger is melanoma, that's what we expect. Not at all. The big killer was you're far more likely to die of respiratory disease in Louisiana than you are in, Ohio, Pennsylvania, and there were New England states. And actually, the deaths from cancer, no increase in deaths from cancer in women, marginally increased in men, but it was liver cancer. So it's an observational study full of all the problems you have with observational studies. However, America's different. You guys live a way lot further south than we do. New England is the same latitude as the Mediterranean coast of France, the Côte d'Azur. Florida is the same latitude as the Sahara Desert. So, you guys live in a different UV environment to us. White skin is not, skin color, white skin in Europe and in China has evolved as an adaptation to the lack of sunlight there. It is not the skin color adapted to an American environment, particularly in the south of America. So, maybe there is a difference there. But the data is not nearly as good as our biobank data. You mentioned the biobank study we did. I mean, I was actually one of the subjects, 500,000 subjects. The assessment at the start took 3 hours. And it took 3 years for the assessment group to move around Britain, recruiting these 500,000 people, mass, hundreds of questions in the questionnaire, all sorts of measurements. And of course, it's then linked in. We have a universal health service here. Everybody's records go into the same health service, same death outcomes, same health outcomes, same cancer outcomes. We have incredibly robust data here for these population studies in Britain and in Scandinavia, because we have these universal health services. And we adjusted there very carefully for the confounders, that the sunbed use, we didn't call it sunbed use, we call them sun seekers, because we were looking at sunbed users as a behavioral marker, because we know that behaviorally, people that use sunbeds seek the sun more. They sunbathe more, they expose more of their skin to the sun. So that was really, we wanted a behavioral marker for sunlight exposure, rather than, and as I always say to journalists, I am not saying sunbeds make you live longer. This is an observational study. You need an interventional study to give causation. I am saying that sun seekers live longer. So there is something about being a sun seeker.
So what do you tell you? So normal patient comes in, they've got, 6 moles that look a little funny, but nothing terrible. They've got maybe an AK or 2, but haven't had skin cancer yet. So normal to low risk patient. I want to hear what you tell them. And then let's take a cardiac transplant patient who's had, 9 squames and 2 melanomas. What do you tell?
They're completely different people. So your bog standard Brit, don't get burnt, get sunshine. We have, what's really interesting is this whole evolutionary thing. How what's fascinating is that pale skin has independently evolved in humans who move to low light areas. So the genetic variants leading to pale skin in China, predominantly, there's about 25 genes affecting skin pigmentation, but it's 3 or 4 big ones. So independently, KIT LG predominantly, white skins evolved in people who moved to China. And independently, white skin has evolved in people who moved to Europe, predominantly SLC45A2. The point is, humans who move to low light environments repeatedly and independently evolve pale skin to make up for the lack of sunshine. Because what skin color does is it determines your risk to sunshine. So as Ade Adamson shows beautifully in America, if you've got dark skin in America, you have no risk of UV-induced skin cancer. I've been working in Ethiopia on and off for the last 14, 15 years. My colleagues there and I've spent about 9 months there, I suppose, we see no UV-induced melanoma, no UV-induced SCCs. Sure, we see acral melanomas. Sure, we see marginal ulcers. Those are not UV ones. So you have no risk of UV-induced skin cancers if you've got that skin. But the big things that kill Black Americans are the blood pressure ones. Blood pressure's higher, with it stroke, with it heart disease. That is what kills Black Americans. And you need far more UV to get that healthy fall in blood pressure if you've got dark skin. And we are putting out this one size fits all message, and it's wrong.
Mm-hmm.
Do you like the Australian, like the new guidelines they put out last year, or do you think even
it's so I think they're being a bit cautious. I mean, I know them all well. I'm Rachel Neal, who's the first author, is coming to stay with me in August, you know, I know those guidelines well. Yeah, so they've said sunlight's got health benefits. We need to think about that. And they've said skin color absolutely determines your response to UV. Look, I used to work in Australia as well. I did internal medicine there 30 years ago, and a bit of work for the Flying Doctor Service. Again, Aboriginal Australians, the original Australians, have no UV-induced skin cancer. They've been there for 60,000 years. They have a skin adapted to the UV environment. But the message is for white Europeans who arrived there when we couldn't send convicts to the Americas. We shipped them off to Australia when you guys left. And and we have this, I have to say, in Britain, we have this, and of course they've got this, you know, slip, slap, slot, the whole UV. That is for white Europeans in a real high UV environment. So I was an internal medicine kind of middle grade doctor in Cairns in Queensland 30 years ago. And in Cairns, midwinter, June, the UV index in the middle of the day is 7 for about an hour. In midsummer, the UV index is 14. So in Britain, in Scotland, we copy the Australian sunlight slip, slap, slot guidance. If you're out between 11 and 3, you know, put on sunscreen. So last year, the UV index in Scotland, Tim, how many weeks do you think the UV index hit 7 in Scotland last year? Just throwing this to you.
I'm going to say 8 weeks.
Okay. Well, Laura, any idea? Maybe you don't know Scotland. How UV index says? Okay, so it was the 24th of June, 5 minutes, just after lunch.
Just after lunch.
And yet,
wow.
And yet,
so I was close.
And the year before it was 10 minutes. The year before it was 10 minutes. So, and yet we copy the Australian slip, slap, slot. It is madness. It is madness.
Yeah. Well, Dr. Well, I want to thank you. So this has been so much fun and so hopefully enlightening for lots of our colleagues to at least start to think about this and think about, you know, making your melanoma patient feel like they should never go outside again. Because that's often what we end up making these patients feel like. So I really enjoyed the discussion today, and I want to invite you to stay around while we move on to our trivia section. So the rules that Dr. Patton has set, we have to let him finish the question, and then as soon as he finishes the question, you just can shout out whatever. If you think you know the answer, shout it out. But you got to let him finish.
All right, you guys ready? These are UV-related trivia. All right. In what year did Hawaii's sunscreen ban targeting oxybenzone and octinoxate officially take effect?
2018.
2020, recently. 2020 is my guess.
I'm going to go with 2019 then.
It was 2021.
Dr. Weller wins.
All right, Dr. Weller wins.
2018 was when the law was passed, but they gave everybody 2 years. And Matt, you were just in Hawaii. Are there SWAT teams at the airport and on the beach confiscating sunscreens and stuff?
You know what? I saw a lot of shady-looking characters, but I wasn't sure what that's probably it.
There's a whole black market, I'm sure, right? All right, number 2. Which form of cutaneous tuberculosis did Niels Ryberg-Finsen successfully treat with concentrated light radiation, leading to his Nobel Prize in 1903?
Tropical lupus vulgaris.
Yes,
Miliary.
correct. It was lupus vulgaris. How would you treat those patients are on death's door. It was lupus vulgaris.
With a bronchoscope. With a bronchoscope. You just get it in there and pour the UV in.
Yeah, that was how Trump was going to fight COVID, I think.
Yes, indeed. That and the bleach. It's going to work.
Hey, I'm not gonna, it's a long dive, but there is very good evidence that UV substantially reduces your risk of COVID death. And Dr. Weller's done a fair amount of that work.
No. I was watching another interview with Dr. Weller where he went over that data. Pretty interesting.
Yeah.
Okay, yes, it was lupus vulgaris. Derms used to win Nobel Prizes, and now we sell $300 skincare lines. All right, number 3. Which popular sunscreen brand was created by World War II airman Benjamin Green, who added coconut oil and cocoa butter to red veterinary petroleum?
Coppertone.
It was Coppertone. That was a little bit of a tie between Dr. Weller and Matt.
I'm taking it. I got Ferris this week.
It was the transatlantic link. I was there first. I really was.
No, exactly. That's why I'm giving you the benefit of the doubt.
All right,
like on a trading floor, you want your computer just next to the data hub because it gives you a millisecond lead.
Right.
All right. Well, Dr. Weller, thank you so much. This has been so much fun, and I'm certainly expecting we'll be having you on again in the future as this story continues to develop, because it is fun to talk about.
Well, thank you. I really enjoyed it. I hope to see you guys at the AAD, perhaps.
Yes, that would be great.
We'll all be there.
Yep. All right. Well, let's move on to the little 3. So these are 3 more articles that we thought were important. There are 3 more topics, but not quite as important as the big 3. I'm going to start us off. And really, I'm going to do 3 articles that are all very quick. So number 1 was that if you got immune checkpoint inhibitor-induced rash, and then you got dupilumab, your survival was better than if you didn't get an immune checkpoint inhibitor rash, or if you got one but did not get dupilumab. Main takeaway from the article that the authors had was dupilumab works well for immune checkpoint inhibitor rashes without making prognosis worse. My takeaway is it makes prognosis better by stimulating your IL-4 system, but that's a pretty big jump. Second one was about the cardiometabolic safety of dupilumab. So this was a large database study in which they compared people on Dupi for AD to people on methotrexate for AD, and people on Dupi for AD to people on cyclosporin with AD. And the main takeaway was that the cardiovascular risks were a little bit lower for the people on Dupi. The main important thing here is that I've always been a little concerned that blocking IL-13 might increase cardiovascular risk, because we know that coronary plaque macrophages are inhibited by IL-13, so maybe blocking it increased cardiovascular risk. This seemed to not show that. And so there were a few that were even statistically significantly decreased, but they were, I don't think it was multiplicity controlled and all that. But then the third one was dupilumab and neuropsychiatric outcomes in little kids. And it's kind of exactly what you would think. Once you go on Dupi, your risk of getting any psychiatric disorder as a child is cut by almost 50%. Specifically, neurodevelopmental and behavioral disorders, mood disorders, anxiety disorders, sleep disorders, learning disabilities were actually cut the most. And then for negative controls, to make sure it wasn't just some weird, you're getting more care or something like that, they showed that accidental injury was not affected by dupilumab use, and they showed that conjunctivitis increased with dupilumab use. So just a bunch of data, that 3 different articles all looking at either ancillary benefits or lacks of harm with Dupi. I don't know, is there anything super interesting that you guys want to comment on that?
I guess we don't have a COI disclosure portion of this podcast. So
I get paid a lot of money by Dupixent, God damn it. But it's not because I get, I'm just as true.
Do you not give enough talks for Dupy? Like this is a big lobbying thing? No, Dupy's great. We love Dupy. I'm sure. Yeah.
All right.
It may be that people with bad immunotherapy rashes are more likely to get Dupy, and the more cutaneous immune-related adverse events, more severe, associated with better,
Yeah.
cancer survival.
and
I'm
I
just
would,
putting that out there. It also may be that Dupy saves lives.
yes.
I'm not gonna.
I'm,
Yeah. All right, I'll go on to the next
all
one.
right, Pat. All right. Pat.
Okay, so this is a little bit of follow-up to sort of what do you do with patients on biologics? Do you switch between classes? Do you stay within the class? Last week we talked about a paper, looking at people who move from one IL-23 inhibitor to another, showing that they, in general had a pretty good response. So this was a JEADV, NAM, and this is out of Seoul, and comparative analysis of switching basically between IL-23A and IL-17. So this wasn't a huge study. There were basically, and they compared them to, patients who were starting naive. And so, most common biologic was about half of patients were on risankizumab, about a third on guselkumab, and about 18% on ixekizumab. Most people, they just were, not switching. And then basically like 21 switched intra-class, and then 22 switched inter-class. And so what you can see here is that basically the patients who switched between classes were more likely to reach a PASI 90 or PASI 100 response than the patients who switched to another drug within their same class. So, I think it's sort of it doesn't detract from what we saw before. I also still think you have darn good PASI responses even if you stay on an IL-23, but some data that if you really are looking for improvement, you're more likely to get it when you switch mechanisms.
First, did it matter? And I know they were small numbers. Did IL-23 to IL-17 work just as well as IL-17 to IL-23?
That's a good question. I think they
I
didn't.
didn't see
I don't
that.
think they dissected it out like that enough to be able to tell.
But
Unless somebody
basically,
else read that and saw better.
so the takeaway that I now have is intra-class switching can work, but it's a higher probability that inter-class switching is going to work.
That is
Yeah.
correct.
I think we talked last week, like we like IL-23s, and so if somebody was failing risankizumab, would you switch them up to the other 23?
Yeah, Tremfya, damn it, Patton. Use the grand name.
Tremfya. And I think we all kind of said back then, probably stick with Tremfya because we like the 23s. Would this change anything, or would you kind of have that conversation with the patient like, look, there's data that suggests you really want to get that really, really good PASI score, let's switch you over to 17s?
I would say, and again, like nobody had less than a PASI 75 response here. Okay, so these weren't like bad non-responders. I would still go to one more IL-23. If that didn't work, I'd go to an IL-17. If they're on an IL-17, I'd say let's go to an IL-23 just because I like the efficacy, safety, blah blah blah.
So we still heart IL-23s.
Yep, heart.
They're just safer.
Yeah.
Oh my god.
Exactly.
All right.
Pat, do you?
What?
Nothing. You don't do any drug talks. I forget how pure you are. Okay.
Well, I wouldn't go that far, but I mean, that's fine. My little 3 paper was from 2024 JAMA Derm. No, 2025.
2025.
Yeah. Gunter et al. Titled C-reactive protein in response to adalimumab patients with hidradenitis suppurativa, post hoc analysis of 2 randomized controlled trials. So they looked at the data from the Pioneer 1 and Pioneer 2 that compared adalimumab versus placebo in patients with moderate to severe HS, and they wanted to see if CRP levels were associated with responses. And they put all the data in table 2, which was a totally confusing table. I feel bad. I called Ferris on Saturday. I'm like, I literally don't understand these numbers. They're all over the place. The point being, adalimumab.
Just like residency. You don't understand, you called Ferris.
Exactly. Overall elevated CRP associated with lower odds ratio of clinical response. Adalimumab had a higher odds ratio of clinical response compared to placebo in both CRP high and normal CRP patients. And then the higher the CRP, the reduced odds ratio of clinical response. I don't know what to take away from this paper. I didn't think it was terribly useful. I mean, if you had higher BMI and more severe cutaneous disease, you had higher CRP. So basically, worse disease is going to be less responsive to adalimumab. I don't think that's a huge surprise. I don't know if this helps us manage these patients at all.
Yeah, I was hoping it was going to be something like if their CRP's this high, then you should use it. But no, it was basically it's more the higher their CRP, the worse their disease. Like that was, yeah.
It's a marker of bad disease, and high CRP patients just aren't as likely to respond. But it's still better to put them on adalimumab than placebo. It's not like they're non-responders to the drug. They just have worse disease that's harder to treat.
Yeah. Right. And you kind of, you know that from, your heavier patients, you're like, this may not work. We might have to bump up the dose or try and go to infliximab, which is weight-based dosing. And the more severe disease, you're kind of like, I don't know if how well adalimumab's going to work. So it was almost like a reflection of the patients that are going to be harder to treat, but that doesn't stop you from treating them.
Yeah. All right, we're going to jump on to our next segment, the baby three. These are all three supposed to be quick hitters. My first one was looking at Pregabalin versus Gabapentin for itch, and here's what was interesting. They work the same for itch improvement. Maybe that Gabapentin was a little bit even better for itch improvement, according to the 5D pruritus scale. But for DLQI, it really looked like Gabapentin was better, and that was primarily because Pregabalin caused more dizziness. And it's a real issue with these drugs, Pregabalin and Gabapentin. I rarely use any of them anymore because there's now data that they increase the risk of hip fractures in elderly patients because of falls. So I use mirtazapine almost all the time. I rarely use Gabapentin because of dizziness and feeling like a zombie. Anything different? Anything else you guys would take from that? Just that it kind of confirmed for me lots of dizziness and that kind of side effect with these drugs.
I never use Pregabalin, so I mean, rarely Gabapentin, some I agree, mirtazapine. It also makes people more hungry, so they put on weight, but that's...
Right, which is often good for old people. Patton?
Right.
I use Gabapentin all the time.
Do you ever use mirtazapine?
I have, but it's usually in patients that fail Gabapentin, and I've not had great results with it.
It's much easier to use in Gabapentin, 15 milligrams QHS.
Probably a habit thing. The hip fracture thing is definitely something I'm going to think about more.
Yeah. All right, let's go into our next one. Let's see here. I think this is Ferris.
Yeah, this is risk of different subtypes of psoriasis following an episode of guttate psoriasis. This is Creedon et al. From Lübeck. And so this was a Trinetics database study. Basically followed patients who were diagnosed, never had a psoriasis diagnosis, diagnosed with guttate psoriasis between 2003 and 23, and then looked at their lifetime risk of developing psoriasis. Turns out that about a 12.5% lifetime risk of getting plaque psoriasis, 7.7 for psoriatic arthritis, and then around 2.9 for like GPP, palmoplantar pustulosis, nail erythrodermic. Most of that risk seems to be in the first 1 to 5 or 0 to 5 years after their guttate diagnosis. So previous estimates were like 25%. This was lower, but this is probably more rigorous and less biased than previous studies.
So useful thing to be able to say to people, 80% chance this is going to be a one-time thing and go away. 20% chance that it's going to come, you're going to get something like this back.
Yeah, really only like at most a 12.5% chance. So
Patton, what do you do when you see guttate psoriasis? Shot of Kenalog, some amoxicillin. What do you methotrexate? What do you if they got bad guttate that you need to do something with?
I'll see if they can come in and get the light box topical tack. Who knows? Maybe I'd give them a sample of Bimzelx. Right, that's going to be a one-time shot. They'll be clear.
Do you give them amoxicillin? Ferris, do you empirically give people amoxicillin?
I don't.
Okay.
No. If they had a strep, I don't. I agree. If they could do narrowband, I like narrowband. I'll try to kind of hit them with like methotrexate, even sometimes, just as something we can do for 3 to 6 months, and then
Yeah.
try to take them off. So
Okay. Do you guys check? Do you send them to urgent care somewhere to get a strep test?
no.
No.
Okay, interesting. Huh. All right, let's finish it up. So, Patton, what's our last one?
Yeah. You know what? I didn't write down the journal and the author.
I think it was
Somebody
in
had that. Can you
Derm
look that up?
storage.
Derm.
Yeah, let me see here. It was comparison of infection rate between sterile and non-sterile gloves during Mohs, updated systemic review and meta-analysis, Sardo et al., Journal of Cutaneous Medicine and Surgery.
Thank you. So meta-analysis of 4 studies, about 3,000 Mohs cases with non-sterile gloves, infection rate was 2%. About 7,500 Mohs cases with sterile gloves, infection rate was 3.1. Essentially no difference, and non-sterile gloves are 10 times cheaper. So I am taking this data to my chair, and I'll take a cut of how much money we save, and I will be rich beyond my wildest dreams. I can't wait.
I think it was. Did you say that the opposite? Non-sterile 3.1, sterile.
Right. So no, it was a lower
No,
rate
it
of
was-
infection with the non-sterile glove.
It was a higher rate. Okay.
Yeah, it was, statistically insignificant, but technically it was 2% versus 3.1.
Okay.
Yeah. That would,
So the only thing I would say when I see these is Mohs is almost all on the head and neck. It's really rare to get infections. Is it different if you're looking at the lower leg?
I learned that Ferris essentially puts her people in like a bubble, like Bubble Boy. He's like, you will not get infected. Stay in your bubble for 2 weeks.
don't talk to your kids. Stay away from your pets.
Exactly.
Take a month off work. LMFA.
I mean,
LMA,
you probably don't need to do the sterile gloves, but I think it's a good point that Ferris brings up. The Mohs on the head and neck, they don't get infected. Lower leg, trunk.
I mean,
I don't think those infections come from the gloves, right? I mean,
No, you're right. I think they come from wound care later.
My takeaway is using sterile gloves for the stuff that we do actually probably doesn't make sense, and it is expensive.
Yeah, I could say it's like $2 a surgery. Pair of sterile gloves is like $2.25. Pair of non-sterile gloves is like a quarter. Or not even a quarter. A pair of non-sterile gloves is like 3 cents. What am I talking about?
10 times cheaper.
Yeah. All right. So I want to thank everybody for joining us today. This was a really fun episode. Next week, we are going to have on Dr. Gabapentini from Denmark. So we're continuing our very hoity-toity tour of people doing cool stuff in Europe. I will
After you badmouth Europeans last week. You're lucky we still have an audience.
And I have to admit something. So I will actually openly admit in eczema. So I believe in my heart of hearts that I'm the smartest person in the world when it comes to eczema. I know that's not true, but I still believe it.
That's good.
Gabapentini is smarter than I am, knows more than I am. If we're going to be talking about hand eczema in particular, I cannot wait to hear what he's got to say. I think there's going to be some really cool stuff. So I want to, again, thank everybody for joining us today. Derms on drugs. Thank you. And if you got questions, comments, or ideas for topics you should cover on the show, shoot us an email at questions@dermsondrugs.com. And I hope you learned a few things. I hope you laughed a few times. And mostly, I hope you're planning to join us next week. Until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.